Thank you for this opportunity to speak to you this morning, on this very difficult topic, to find the gaps between policy and practice in managing HIV disease in our region. And also, this will help you to mind this gap, to plug it so that, we won't go into the disaster in future. So in my talk, what I'm going to do is, so when I'm talking about policy, I'm going to refer to the guideline. So the guideline which our region, especially the countries adapt, is the one from the WHO. Either they adapt the next day or it may take a couple of years. While doing so, we are going to face so much of gaps from those policy, from our practice, which I'll walk you through, and we can have a discussion again how we can mind these gaps to plug it up so that we won't have a disaster in future. As you all know that how these guidelines have evolved over a period of time. This is something, that dramatic things have happened, over a period of years. How we initially started treating only the sickest people, then over a period of time, we ended up now, treating, everybody. And also, we had only one line of therapy when we started our career in HIV medicine. Now we have got all types of medications. And also, we have all types of monitoring, tools, not only in the developed world, but also in the developing countries. So we do have all these tools, and we do have all those guidance. Still, we do have gaps. That is because we don't implement them at the appropriate time. Now, coming to our epidemic in our region, which I'm sure you would have seen in this conference many times, which again I'd like to show you as part of my talk on the gaps. So this is something what a number being given to me by the UNAIDS. So till 2016, they will be releasing the 2017 data next month at the IAS conference in Amsterdam. Now we have estimated around 5.1 million people living with HIV in our country. But very importantly, India is still less than 50% on treatment. So that means we have not found a lot of people. So this is a huge gap, which you all know that if we don't find them, we are not going to prevent HIV transmission, as said by many studies. So how we can plug these gaps? So I'm going back to my own country. I'm from India, where you all know that one of the largest HIV epidemic in our region, where it is estimated around 2 to 2.5 million people living with HIV. We have predominantly heterosexual transmission, but now growing number of infections among MSM and also among people who inject drugs. And again, in our region, it's only around 1.2 million people are currently receiving treatment out of the 2.5 million which is estimated. That means still only around 50%. But on the other hand, our region as well as in India, there's a huge decline in HIV incidence and mortality. So now, how we can find the other people who are not on treatment and who do not know their status? So we need to do our own exercise in our region, how we can identify them. One size doesn't fit for everybody. For example, for India, we did a work in collaboration with our national government and with a cost effectiveness group in Harvard University called CPACC. We did a simulation model how we can find these HIV-infected people in India who do not know their status. We use local prevalence, incidence, and cost for testing, counseling, and linking to the care, and may not have much time going into the details of this work, which we published a couple of years back and presented to our national government. But on the hand, I'd like to summarize the conclusion. What we said is, India being a very large country with 1.2 billion people, the prevalence is very low. But on the other hand, we have huge numbers, and also HIV has been evolving epidemic among the key population. If we offer voluntary HIV screening among the national population every 5 years, you'll have a substantial clinical benefit and cost-effective. And annual screening, which will be cost-effective if you do among the high-risk population, among MSM, injecting drug users, female sex workers, and in some high-prevalent districts in India where HIV has been evolving. So this is something what we did a model, and we are presented to the national government, and they have been working on how to implement this to identify these people. I think similar type of strategies, already Thailand has developed that, which Nitya was talking to us yesterday, but other countries should develop their own strategies to find people to link to treatment. Otherwise, these gaps will continue to present. So this is again data from UNAIDS, which very clearly shows that our region already misses a new infection targets. So this is something, what's already gone. So if you don't do it at the right time, so you'll miss the bus. So because this is a moving target. Next, moving to treat all, so which we all know that we have no questions and no scientific questions against on anything on this. We know very clearly that both HP10052 and START study very clearly showed we need to start treatment early. And also, when this was being launched, our region was struggling to put everyone on treatment because of the cost. Then our group, and as well as the group in South Africa, we did cost effectiveness analysis, especially on starting treatment on the HPT and O52 data, and which shows very clearly, especially in my region in India, where it will be very cost effective if you start treatment at a higher CD4, especially among serodiscordant couples. And subsequently, region started putting people on treatment in that group. So today, now this is again, a slide from WHO, which shows that the treat-all policies is almost been implemented in many regions. And again, if you look into our region, I'm so glad to see that most of the countries are in green. That's great. So that means test-all, treat-all, policy is being getting implemented. So while doing so, I think yesterday again we discussed about on same-day start and as well as rapid ART initiation. It's time to go ahead and start doing this. Let us not RV against, let us not do rapid ART. Let us not do a same-day ART. I think it's a great window of opportunity. Now our region has moved forward. I think go ahead and doing that. We may face a lot of other clinical issues, but on the other hand, in a public health setting to prevent loss to follows and prevent early mortality, this will work. We have guidance, and Dr. Pauline Chan will be talking to you a little later when you talk about this advanced disease on this. Now, moving to the treatment, which again, it's evolved over a period of years from multiple difficult, so toxic drugs to better drugs today. And today also in the guidelines, there is an alternate regimen, which you heard a lot about from our earlier speaker on dolutegravir. So again, whether our region is prepared or should move forward with this regimen as soon as possible. Let us see this. Yesterday, we also have some, discussions in the sessions and as well as arguments on still using efavirenz for first-line therapy as part of the public health programs. Just go back to this data, very clearly been shown in 4 of those ACTG clinical trials. Out of those, one of those trial called ACTG 5175, which I co-chaired with along with 4 others, again, which we recruited participants in our regions, in India and Thailand, and of course a lot in Africa, and as well as in the United States and Latin America. Very clearly showed, suicidality, is a high risk, following efavirenz. While seeing this, again, why we need to further, do with this efavirenz. Suicidality is such a, you're losing your purpose. Someone who put on treatment at 999 CD4, and next day, someone from their family come and say, my near one committed suicide. This is something what you don't want to do that. And also, this has been further been supported now by the START study sub-analysis. Also shows that someone who has got any previous history of psychiatric history, high risk to, develop, suicidality. Again, you all know that as clinicians, every HIV-infected people in our clinic have some sort of a psychiatric illness, which again, very hard to encounter at the early stage. It takes time and years. When you put on treatment at a high CD4, especially with these drugs, efavirenz, people tend to do this. I think this is the right time that our region should move forward, towards dolutegravir. And one other thing is now, we have these new data coming up from different regions on the baseline NNRT resistance. So again, if you see these on x-axis is various countries, and y-axis is percentage of NNRT resistance. If you see this, red color line, which is 10% prevalence, which is something a ballpark to change from the current regimen, most of the countries in sub-Saharan Africa has gone beyond that. And if you take our region, still we are less than 10%, but again, this is all data from 2014 or 2015 survey, and today we are in 2018. So again, we are just a little under 10, and it's a matter of time, we may, hit the button on 10%. So let us not wait for that, just move forward towards other regimens which has been recommended by WHO. Now also we have a guidance very clearly, if any regions who have got 10% or more, they have to move towards a non-NNRTA containing regimen and with an dolutegravir. So our country, our region should be prepared in any time to move forward, not only because of this resistance, but also because of other efavirenz-related toxicities. So then you may ask a question, cost, how we are going to bring this dolutegravir in our region. You heard wonderful lectures again from our earlier speaker, Dr. Garrel, in the earlier sessions, how much, it's been tolerable, how effective it is. So, but you may ask a question, whether our region can afford the cost. To solve this, our group did a cost effectiveness analysis using dolutegravir, especially for India. So we use cost of the drugs, especially from the generic manufacturers. We also use a cost when someone who is on efavirenz, if they fail, based on the durability, which is much shorter as compared to dolutegravir, and also, risk to develop an, opportunistic infection. And also, we also put in the model, someone who has been viremic with efavirenz, chance chance of transmission into the model, and we found that a generic dolutegravir regimen for first line in India will increase survival, decrease proportion of patients switching to more costly second line ART, and also we used a cost at that time of $102 per patient per year. But now, the cost which is estimated is much lower than that. It's only around $72. So based on this analysis, very clearly, we recommended, my region, India, should move forward on that, and we have been advocating with our national program to move in this. Similar strategies should be done in our region, other countries, how you can, develop and, talk to your policymakers with your relevant, data to move forward towards a better regimen in our, region. Then you may ask a question, hey, in India, you do have your generic drugs. What about your, other, countries in Asia? So this is a map, again, presented to me by MPP, and as well as thanks to the Treat Asia's very nice report, where I got this map, where you can see all these blue-colored countries, or countries in our region covered under for both adult and pediatric voluntary licenses for dolutegravir. So WHO, along with MPP, have done negotiations with the innovators, with the generic manufacturers to develop these molecules. So most of the countries in our region have this license. So this is time that you have to negotiate with them how to get them and get it registered in your country to get to the patient. We cannot say that the drugs are not available. It's already been developed a platform. It's up to your policymakers in your region to get it done, get it into your guidelines. Now moving to these monitoring, we have been talking about viral load monitoring forever, so whether our region has implemented. So again, as clinicians, you all know that viral load monitoring is very important to identify failure, to prevent opportunistic infections, but also the HP10-052 study, which you all know very clearly showed that if someone who is viremic, there is a higher chance of transmission. So that means viral load monitoring is not done. You're not only doing a good clinical practice, but also you may end up in transmitting infection to others because of you do not know who has been viremic. So again, if you look into this map, again in our region, very glad to say that many countries have adapted, but still some of those is large epidemic like India, still not adapted completely, and they didn't adapt till last year, and after strong advocacy, now they started with a very, very, very small phase through small number of clinics. So this is something, again, very much been concerning. Again, the reason which many of those programs which didn't implement talk about why they didn't do viral load is either because of the cost or because of the lack of technology. We again did a cost effectiveness analysis for our national program, using the cost for the various viral load kits and the technology, and we found that definitely it's going to be very expensive. So you need to project this cost to your national program, because not only the testing cost, but also the minute when you do that testing, more number of people will need second and third line therapy where the cost will go up. But if you put all this cost on a long run, it will be cost saving to the program as an individual because of morbidity, mortality, prevention of resistant strains, and as well as various opportunistic infection. If you put everything into the model, it will be cost effective on a long run. Again, you also need to do this type of mapping for your program managers to forecast how much money is needed when you add new tools into your guidelines. Now, what about other therapies and second line and third line, which you all know that these are the various drugs till today approved for use. And again, out of those, most of these drugs have been available in our region through generic manufacturers. All these black-colored, drugs have been, available through our manufacturers. And also now we have these WHO guidelines for second line and third line. And also heard from WHO that most of our countries in our region have implemented second line as well as a third line. So let us not sit back and say that we don't have the drugs. We do have the drugs. Guidelines are available. I think we need to provide this to our patients to provide the continuum of care. I'm going to end my talk by showing next 2 or 3 slides to show that it's not only just the HIV, opportunistic infections and first line and second line, but now our patients live longer. You heard again and again from yesterday and today this morning, with better drugs, they live longer. So this is the data which we published from our cohort in Chennai, 5 years back, that, significant number of patients today in our clinic, they have been living longer with antiretroviral treatment. This is again a data of almost like 5 years back, more than almost 1,000 patients on more than 10 years. We analyzed almost 82% of them still had suppressed viral load. And very significantly, at that time, we also used a lot of drugs like AZT and D40 and favorins. Still 58% were on first-line therapy. But on the other hand, what we started seeing in that cohort is why they fall sick and get admitted in our inpatient facilities, either because some of those cardiovascular disease, which you all know that either due to drugs or due to inflammation, or with renal disease, and worsening of diabetes, and liver disease, and of course, cancers, and neurocognitive effects. So this is something what we started noticing almost 5 years back. Again, similar work being done now through our Treat Asia network, which some of you have been familiar with this, where a study which has been done in our region, across all these Treat Asia sites, almost around 7,752 patients with a median follow-up of 6.6 years. What's been shown in this particular graph is a cumulative incidence of causes of death during the first 10 years of ART. If you see this red color one is the one due to cardiovascular disease, and the one on the blue line is all AIDS-related one. So still, the cardiovascular disease is very minimal as compared to the AIDS disease, but still being present. And also other ones are non-AIDS-related one, and as well as unknown causes. Again, we concluded that particular study showing that the higher rate of CVD events in higher income countries compared to the lower middle income countries, this is not because it's not been present, because it's all been under diagnosis, especially in our resource limited settings in Asia Pacific. This is another gap. If you don't do all those investigations to identify these NCDs, you're not going to find them. It's already been there. I think it's the right time that we need to do this to get these patients into care or prevent non-communicable diseases. So one such interventions we are doing through NIH is a study called REPRIEVE, ACTG 5332. It's a larger randomized clinical trial where we use statins against placebo in HIV-infected people to prevent the cardiovascular morbidity. The study is still ongoing. Again, proud to say that out of the 111 sites across the globe, there are 3 sites in our region, in Chennai, Bangkok, and as well as in Chiang Mai. We have almost enrolled all 3 sites together, almost nearly 1,000 patients, and we have contributed immensely, but we had to wait for another 3 years to get whether we can prevent cardiovascular events using these statins. A slide on oral PrEP. Yesterday we had an argument and a very nice lecture by Dr. Nithya Panapak. Again, our region have implemented. We have guidance, but still not available. And Nithya very clearly said it's been available to people only who participate in demonstration projects. Again, in my country, still not been implemented, but we are in the process of doing a large demonstration program because our national program wants who is going to provide PrEP, whether it is going to be provided through the clinic or through the community program. So we are going to do a large randomized clinical trial to test this is something, how we are going to implement this. I think that they might be right because they don't want to waste this opportunity. They want to do it in the right way. Again, our region have to study how we are going to implement, but let us not delay. Let us go forward with PrEP to prevent transmissions. This is another work done by our Treat Asia group and published a few years back. So what we did in this particular analysis, this is to understand the improved survival among HIV treatment programs in our region. So this analysis was carried out almost around 16,000 odd patients who have received care from different countries in Asia between 2003 and 2013, which you all know that they would have used various types of guidelines, starting from less than 200 CD4, 350, and more than 500. So we did the survival probability at 4 years of follow-up for those initiating ART between 2003 to 2005, and it was around 92%, which increased to 94% when it was being received care between 2006 to 2009, and to a little higher, which was statistically significant in 2010 to 2013. So this very clearly shows that if you use better guidelines, our patients do well. That's because we use better drugs like tenofovir as compared to AZT, and patients started at a higher CD4 cell count, and CD4 monitoring and viral load monitoring to some extent was used during those analyses. So this is, again, very clearly shows that if you do an analysis now with the current guideline 2016, you might be better, and might be the future guideline, it might be 100%. So if you don't implement all those guidance at the appropriate time, you will not get the benefit from our cohort. So this is what UNAIDS have modeled. So if you don't test and put everyone on treatment, you're not going to see this fruit. So if you do that, we'll be able to avoid almost 21 million AIDS-related deaths and will prevent 28 million new infections by 2030. So I think our region, now we have put only less than 50% of the people on treatment. We have to do a lot of work to move forward. I like to show this quote. This is something what I found in this from our Nobel laureate from Myanmar. Sure, too many people are facing isolation, loneliness, hopelessness. We need an Asia-Pacific community of compassion to end discrimination. I think this is true. If you don't do that, people who have got risk factors don't come out for testing. We will not be able to find them. We will not be able to link them to treatment. So this is what everybody is talking about cascade, in different regions. So this is a cascade of our region where, people who have been, identified, were put on treatment, and as well as, who have been suppressed, still less than 50%. But one thing very interestingly is if you go back to the same cascade in our region, among the people who are aware of the HIV status, 66% of the people on treatment. That's good. So that means we've done a good job. So if you know them, you put them on treatment. And among the people who are on treatment, 83% are virologically suppressed. So that means something we have to plug it in this gap. If you identify everybody, probably we'll be able to suppress more people on using this treatment. So that means identifying these people is the most important thing to get the final 90. And again, don't sit tightly with the guidelines. Now WHO is like a moving, bullet train, where the guidance keep coming up, every other month or every other year. So now we have new guidance. There will be new things will come up next month, and as well as new revisions will happen in 2019. If you wait, you'll be lacking, and you'll have a huge gap. Then you have to work around, how to, plug the gap. I like to conclude my talk showing that a lot of progress on scale-up of ART has been done in our region. I won't use the word extraordinary. Initially I put extraordinary, but after seeing this only less than 47%, I just cut this extra. We are only ordinary. We have to go back to extraordinary. Definitely we have seen decrease in morbidity, mortality, declining incidence. There is no doubt on that, but we can do a better job. But very importantly, we have all those tools available and drugs available, very importantly about the sustainability of ARVs. Stockouts are happening in certain programs in Asia. And also, we need to have forward-looking policies and more effective and innovative approaches together with further investments. If we don't plan all those, we'll not be able to sustain this over a period of time. I think we have to give a lot of emphasis to prevent the transmission of resistant strains by implementing viral load monitoring and switching people who are failed. And also, we need to give a lot of emphasis in our region to prevent and manage non-communicable diseases. Need to be implemented in Asia soon. And of course, we need cost-effectiveness studies, need for program managers training so that all those guidance can be implemented at the appropriate time. I may not have much time to go back and talk about hepatitis C, so this is something we cannot ignore. Yesterday, Dr. Pauline Chan shown in her talk that we contribute almost 1/3 of those hepatitis C epidemic from Asia Pacific region. So this is again another work from our region in India. We have been doing this in collaboration with our national government in Northeast as well as Northern India, where HIV injecting drug use epidemic is, HIV hepatitis C epidemic is very high among the injecting drug users. We do have a test and treat approach where we do testing both for HIV and hepatitis C in this community and link them for treatment. We need such efforts throughout our region to contain this evolving hepatitis C epidemic. I'd like to thank several people who helped me with this presentation, give innovative ideas. Dr. Mayer, was my mentor for years. My colleagues from Treat Asia, somebody gave slides, some slides has been stolen. Thank you very much. And also, Marco from WHO and Chai colleagues, and particularly my chair here, Tri, who gave me ideas, what I should speak, what I should not speak. Thank you very much.